University of Pennsylvania, who is interrupting his vacation to give us a talk on the behavioral economic insights into physician tobacco treatment decision-making. But before I introduce him, let me mention some housekeeping issues. So as you know, for CME credit, you must sign in and you must include your email and credentials. Do not miss our November 1st Tech Talk with Joseph Ikas. Also, please note that the next ID series, the October 19th ID series, we will have a special guest, one of our own, Dr. Stephanie Guarino from Christian Care from here. And as always, please register to help us prepare, and the full schedule is posted on our website, DE-CTR.org. So Dr. Leoni is Professor of Medicine in the Division of Pulmonary Allergy and Critical Care at University of Pennsylvania School of Medicine, and he also directs the PEN's Comprehensive Smoking Treatment Program. He's also a Senior Fellow in the Leonard Davis Institute of Health Economics. He obtained an MD from University of Pittsburgh and a fellowship in pulmonary clinical care from Jefferson University. What did I say? Oh, okay. He also obtained a Master in Science in Clinical Epidemiology from University of Pennsylvania. He received multiple awards over the years, the last one in 2016, which was the Scott McClure Award for Excellence in Substance Abuse Teaching from the School of Medicine. He was the chair until 2017 of the Tobacco Action Committee at the American Thoracic Society and a member of the e-cigarette subcommittee at the Scientific Advisory Committee from the American Lung Association. He has been PI and still PI or co-investigator on multiple federal and foundation grants, and all these projects are related to tobacco dependence treatment and to the social science of tobacco control and treatment decision-making. He has a very long list of peer-reviewed publications. He's a teacher and a very popular speaker nationally and internationally. So we are, So we are delighted to have him here giving us a talk today. Thank you very much.
Wow. Thank you guys for such a kind introduction. I'm delighted to be with you. I wish I could be there with you in person, but I do appreciate the invitation and the overwhelming, really, interest in tobacco dependence at Christiana among the faculty and staff there. There's so many folks that have been interested in this topic from so many different perspectives. I'm thrilled to be able to talk with you today. I wanted to talk a little about some insights that we came to over the course of the past few years around clinician decision-making. And this work really stemmed from kind of the notion that, you know, the first set of guidelines, national guidelines around how to treat tobacco dependence really came out in 1998. That's a long time ago. That's 20 years. And very little of the clinical behaviors around tobacco dependence have systematically changed. Of course, there's lots and lots of individual practitioners that have changed the way they think about things, the way they engage their patients, et cetera. You can find plenty of examples, but from a systematic point of view, the culture of healthcare really hasn't shifted very much when it comes to thinking about tobacco dependence in general. And we wanted to explore some of the potential reasons why that's the case. Next slide. This is my disclosure slide. I have no commercial relationships. I do get some financial grant support from a number of different federal, state, and regional nonprofit organizations, and I'm employed by the University of Pennsylvania. Next slide. The objectives for this morning, I want to try and review the state of affairs regarding physician engagement in tobacco dependence treatment. I want to try and identify a few behavioral economic motivators that act as potential rational obstacles to management in complex patients who use tobacco. And then discuss the potential role of fundamental attribution error in the implications for future approach to training. So the premise goes something like this. Next slide. This slide is meant to represent the sort of archetypal patients that you guys all interact with on a daily basis. I call this woman Mary, although I don't actually know her real name. This is just a picture off the internet, not a real patient. I imagine Mary to be about 65 years old and suffering a number of different comorbid conditions: COPD, hypertension, cardiac disease, diabetes, and of course she's a current smoker. And you know, Mary shows up dutifully for her follow-up appointments, and she takes all her medications, and she's always asking good questions about how she could be better and what she can do to feel better. And she comes into the office and asks about lung volume reduction surgery to breathe better. And both people in that interaction sort of know what a core part of the answer is going to be. Mary understands that her current smoking, her continued smoking, is impacting her well-being in a number of different ways. And the clinician in that office visit recognizes that if we could just sort of, quote, get Mary to stop smoking, then lots of things would actually end up getting better. Next slide, please. But here you should be on a slide that's where the title is The Problem. This is really how I view the problem. We've done these studies, you talk to physicians, you give them a bunch of questionnaires, and the endorsement rates are actually quite high. Clinicians really understand the importance of tobacco dependence in Mary's trajectory. They understand the impact that abstinence from tobacco will have, and they express a real interest and a real desire to do more and to be effective and to provide high quality care. But all of those endorsements don't translate necessarily into what I think of as engagement rates. And by engagement rates, I mean something a little bit more sophisticated than simply counseling that smoking is bad for you. In other words, an engagement rate might include things like actually writing the prescription or sitting down and talking about ways to stop smoking as opposed to the goal-oriented speak, Mary, you must stop smoking, to really engage with implementation-oriented speech, like here's some ways to think about this is what I want you to do. There's very few referrals that are made, and then follow-up specific to this problem is almost never part of the medical record. So if endorsement rates are really high, but engagement rates are really low, that asks the question, what's the process by which physicians are making these decisions regarding these two competing priorities? Next slide. And if you look in the literature, there are a number of different reported obstacles to change. People answer these questions in ways that you would imagine they would answer the questions. Tobacco treatment takes too much time. I don't get reimbursed. I have too many other priorities. Of course, I have to take care of Mary's breathlessness. I have to take care of her chest pain, and I have to take care of her hemoglobin A1C. That's 10. And how am I supposed to do all that in one visit? And then finally, there's really this notion of Mary's reluctance to quit smoking. How am I supposed to deal with that? As a physician, if I say, hey, Mary, I need you to stop smoking, and Mary says, I'm not ready, or I don't want to, or even just the look on her face turns sad, I don't want to undermine the totality of our therapeutic relationship by pursuing a topic that maybe is uncomfortable for Mary or off-putting in some way. And so how to deal efficiently with that reluctance is a core obstacle to changing behaviors. Next slide, please. This next slide actually is by way of background on something called buy-sell price preference reversal. And this was a phenomenon that was originally identified in the late 60s. It was written about extensively in the early 70s. And a lot of the psychological work that was done around this used pretend lottery tickets. They talked to people about, they pretended to be from a state lottery association. And they did a bunch of interviews of people where they asked, hey, we're thinking about instituting this new lottery. I have a ticket here called Lucky Bucks. The odds of winning are 1 out of 10. For every 10 people who buy a ticket, one person's going to make make the money. And the payout for that 1 out of 10 winning is $40. And then they talked a little bit about the other alternative ticket that they were considering, and then we'll call that day at the fair. And the day of the fair ticket is a much better chance of winning. The odds of getting paid out are 9 out of 10. But if you do win, you only win a little bit of money, $4. And so if you do the math, approximately in a population of people, the actual winnings for these lottery tickets, approximately the same. If 1 out of 10 people wins $40 and 9 out of 10 people win $4, you're basically in the same winnings category. But when you ask them, how much would you be willing to pay for this ticket? The answers came out different than if you asked the question, how much do you think other people should pay for the ticket? And so if you hit the space bar or something, you'll see the arrows pop up if they haven't already popped up. The ticket with the high payout was valued more highly for the community. Like folks outside in the community are much more likely to, the ticket that pays out more, the bigger winnings should be more valuable to community members. But that's different than how much you should invest in a ticket. When asked about how much do you want to pay for the ticket, the payout was not as important as the odds of winning. What's the likelihood of a successful outcome at the end of this lottery transaction? The likelihood of success is much more important at influencing investment from the self perspective, whereas the payout, the value to society, is much more influential from the other perspective. Next slide. A preference reversal, this is really just saying the same thing over and over again. So in the perceived value to the community or other of tobacco use treatment may be high because of the large anticipated return on morbidity and mortality. But the utility of focusing on tobacco treatments to self, how much I'm willing to invest of myself, may be low based on the low perceived likelihood of a successful interaction. Will the patients follow advice, adhere with medications? Will the insurance pay for the treatment I prescribe, etc.? And so we wondered whether or not there was a potential preference reversal with relation to tobacco that may be limiting engagement, not based on value to the community, but really based on perceived likelihood of success. We first started actually doing some local interviews with folks, basically open-ended interviews to try and identify the types of things that influence perceived likelihood of success. And we identified these 4 cognitive biases or heuristics that seem to influence probability of success most fundamentally. And I'll just review them a little bit. Up at the top is availability bias. Availability bias is where recent or memorable events hold exceptional sway in decision making. And so you can imagine that if I'm a cardiologist and I'm taking care of Mary's recent MI and I say to Mary, I need you to stop smoking so that you don't die. And then on the next visit, or maybe even later in the hospital stay, Mary's caught outside with her IV pole trying to sneak a cigarette. That is a very dramatic, very persuasive, very highly available event that will then color my interpretation of probability of success from that point forward. There's also focusing effect bias, and here this is really where decisions are influenced more by short-term concerns than by long-term concerns. So, for example, if Mary comes in and she's short of breath today, I have to figure out which inhaler to give her or how to turn up her oxygen or something, because I can't let her out of the office still short of breath. When even though my intervention at this moment may be less successful over the long run at preventing future shortness of breath, I'm going to focus on that one because it's something I need to do right now, even though dealing with the smoking may be more effective in the long run. And then there's impact bias, and this is a little bit of a funny one. Impact bias actually refers to the impact on my life. So my decision whether or not to treat is influenced by my projection of how much investment I got to put into it in the future. So you can imagine, as a pulmonologist, I might be in the office and Mary, I want to talk to Mary about smoking, and then I say to myself, oh my, if I ask her about this, she's going to cry. And then I got to talk to her about her relationship with her mother, and all this stuff is going to happen that's actually off to the, in the weeds, and I don't know how to deal with it. And that my perception of this cumulative impact on how my day is going to go has a tremendous influence on the decision of whether or not to engage. And then finally, we identified omission bias. And here, omission bias is the tendency to prefer inaction in an effort to avoid harm, even when inaction may cause greater harm than action. So this is, the classic paradigm. Well, I'm not going to give a heart disease patient a patch that has nicotine in it, when on the other side of that exact coin is, but if I don't give them the patch, they're going to continue smoking, and I know that causes, that's going to increase the likelihood of the next heart attack. So these four biases we identified as potentially influencing the likelihood, the perceived likelihood of a successful interaction, and we thought to ourselves, if we can identify this and actually deal with this, we may be able to change this preference reversal. Next slide, please. And so reframing bias was kind of the objective of our training program over the course of the next year or so. And we wanted to try to directly increase the perceived likelihood of success by systematically addressing each of those predictable biases within the familiar context of chronic disease management. So here, the twist is that we're not really just teaching on content anymore. We're not just saying this is a patch and this is how you do it. We're teaching on the biases that influence decision-making, and then within that context, talk about the patch and some of the biases that influence our perception of the success, the potential success of the patch. Next slide. So here, the first question is buy-sell price reversal operant in the case of Mary? And we think it is. Next slide. In our first series of interviews, these were open-ended questions that we, this was a closed-ended questionnaire that we administered to 42 primary care physicians at Stanford University. And the question, how important is it for Mary to stop smoking? Everybody's answer is on the right side of that scale. Everybody says extremely important. So they recognize the utility of it. But then next slide, please. When we ask how likely is it that you will have a successful smoking-related interaction during this visit, the majority of answers are on the left side of the scale. Not at all likely, somewhat likely, a little likely. There was one or two people that responded extremely likely. And the difference in distribution between those answers was significant. So this was our very first indication that perhaps there was a difference between the utility of it, the perceived likelihood of success, and how important it is to the community. Next slide. We wanted a way to actually compare what's going on with tobacco in people's minds compared to other chronic illnesses that are typically seen in primary care practice. We chose hypertension and diabetes as potential comparators, mostly because they're highly prevalent illnesses. They're familiar to lots of people. They have lots and lots of different treatment strategies available. But hypertension is generally viewed, you can imagine hypertension might be something that's completely out of operational control by Mary. Mary has nothing to do with whether or not she has hypertension, or I should say very little to do with whether or not she has hypertension. On the other hand, diabetes, while there's, all the biological influences, there's a lot to do. Mary has a lot of behavioral stuff that she could be doing in order to prevent the long-term complications of diabetes. So we thought that these would make two reasonable comparators to what's happening in tobacco. And in order to compare apples to apples, we needed some denominator that would sort of unify people's ability to express importance. And we decided that we would try and change everything into dollar values, because every respondent has a approximately the same understanding of the value of a dollar. And if we could get everybody to answer in terms of dollars, then we would be able to compare legitimately across illnesses. And so the first question I want to tell you about is we set up a scenario. Imagine you have $100,000 to spend on healthcare resources. How would you distribute the money among each of the following problems to make the biggest impact on your community? There, we did not define impact. We let the respondent define biggest impact in any way that they felt was correct. And the distribution of dollars spent, you could see people place value. They prioritize tobacco above hypertension and diabetes in terms of the impact to the community. And this was done in a sample of 63 clinicians, primary care physicians, nurse practitioners, physicians assistants that volunteered to participate at an American College of Physicians meeting. Next slide, please. The next question was, imagine there are 3 new patients on your schedule. You're given $100 to bet on the likelihood of a successful interaction during this visit. How much would you bet on success if for each patient, if their problem is tobacco, hypertension, or diabetes? And clearly here you see that people feel much more confident in a successful interaction if the problem is hypertension and or diabetes than they do if there's tobacco. And this is like another indication that there's a price reversal here. And even when you standardize dollar for dollar and you're trying to give a more quantitative, do a more quantitative analysis of just how much more confident, it still holds true that they see the value to the community as very high, but their confidence in a successful interaction as relatively low. Next slide. So what we tried to do then, in order to actually kind of identify change over time, we needed to index these values to one of the chronic illnesses. We chose diabetes as the chronic illness comparator. And so what you're seeing here are graphs that say, essentially, for every dollar I spend on diabetes, how many relative dollars would I spend on the utility of, say, for example, hypertension? And here, utility of hypertension, they value the impact of hypertension treatment as 29 cents less valuable to the community than diabetes treatment. Okay, but the probability of success of hypertension treatment is valued as 21 cents more probable in terms of success than diabetes. Okay, so that's the sort of standard. That's the comparator pattern that we see with hypertension, how people value impact versus likelihood of success. And there's a reversal on the right-hand side of this graph where it says that compared to diabetes, I see the impact on my community of tobacco interventions as 14 cents more important. But I'm willing to invest 56 cents less, that's less than half, on the probability of success. I feel like there's much lower probability of success with a tobacco intervention. And there's our price reversal right there, and this quantifies what the degree of price reversal is. Next slide. So what we started doing is we started going to different organizations and training people using the sort of bias reframing method that we talked about earlier, and look to see whether or not we could affect that price reversal phenomenon. And in this group of 12 physicians at Tulane University, you see pre-instruction is the classic pattern, where on the right-hand side of the graph, tobacco is valued very highly to the community, but likelihood of success is relatively low. Next slide. You should be looking at a slide that has a red circle on it that's over a 35-cent marker at this point. Is that correct?
Yes.
Okay. So compared to the previous slide, all of a sudden now, not only do I still have a relative value of the community for tobacco compared to diabetes that's very high, for every dollar they spend on diabetes, they're willing to spend an additional dollar on tobacco in terms of utility to the community. But now all of a sudden, my probability of success for tobacco has actually gone up. And in fact, this group of clinicians sees themselves as more successful dealing with tobacco than they see themselves as dealing with diabetes. And that to us was actually a very important flip that actually ended up being sustainable over time. Next slide, please. So this next slide is titled "Remember Stanford Pessimism." This is just a sort of a recall back of what things used to be like when we were at Stanford. Everybody was responding on the left-hand side of this scale. We went back to visit with the Stanford folks, I forget, 2 months later, after training them on inherent biases, cognitive biases around success, and their responses were on the right-hand side of the scale. And this was highly statistically significantly different than the pre-instruction responses. So we think that more than just speaking about content, this is a patch and this is how it works, we need to give clinicians basically a framework that discusses the biases that have been ingrained in all of us, really, from literally from kindergarten on. If we deal with those and bring them to the forefront, make them cognitive, so to speak, clinicians are actually able to integrate the content information in a more effective way and be more likely to see, to experience or to feel a probability of successful interactions if you reframe what success actually looks like. Next slide. So this is basically this, we tried to use this method to bring it into a larger practicing community. Instead of doing small survey groups, we really wanted to get at larger groups of practicing internists. And we started what we call the Philadelphia COPD initiative. And for about a year and a half, we went all around Philadelphia talking to people in the community on the ground about COPD, the connection to smoking, the importance of treatment, and the biases that keep clinicians from engaging more effectively. And then gave them content, a strategy for dealing with tobacco in the office. And we looked to see whether or not we could affect change. Next slide. We called the person who was in the field the academic detailer, and the activity that the detailer was doing we called the AD goals. And the three main points that the AD had when she was going around the community was the notion that dealing with reluctance to quit smoking was simpler than clinicians were taught to believe. That smoking treatment takes too much time. We wanted to give them a framework where it's short and sweet and effective. And then don't get reimbursed, kind of reframe that problem away from smoking cessation as a model to treatment of tobacco dependence as a model, and showed clinicians how they get reimbursed for the treatment of tobacco dependence. Next slide. The durable materials that we produced, we had a whole bunch of things. We had a big old introductory brochure, a monograph, a website, quitline information. We gave them copies of the guidelines for sort of the definitive content source. We gave them a couple of reviews, and we gave them something called unads. We actually, after the in-person AD visit, the detailer would spend time sending letters to these clinicians with flyers that were included inside that were meant to, on one hand, give valid scientific information about how to treat this problem. On the other hand, try and undermine the biases that we felt were the biggest obstacles. Next slide. And so this is an unad that we produced around focusing effect bias. Ever feel that you'd like to talk to your patient about quitting tobacco, but a few other pressing problems keep getting in the way? Can't ignore the problems right in front of you. Don't ignore the problems sneaking up behind you. And then at the bottom, we gave them just an educational blurb and a couple of references. And that big picture is literally the big picture is really what we're counting on to be this kind of thing that would remind clinicians that focusing effect is natural, it's legitimate, but we can do more than one thing at a time. And so I need to deal with breathlessness by changing the inhalers around, but I also need to deal with breathlessness by addressing the tobacco. And so that was sort of our approach to focusing effect. Next slide. This is omission bias. So there's the big picture here is a Marcus Welby style physician with a diploma in the background and a big, beautiful office with lots of books, holding a magazine with a picture of the brain. Some would have you avoid the problems associated with prescribing smoking cessation medications rather than avoid the problems with not prescribing them. And here, we want to emphasize that there's a problem with the decision not to prescribe cessation medications. Don't be misled into thinking your patients are safer without pharmacologic help. Again, an educational blurb, a couple of references, and off to the races. They got these unads around all four biases that we felt were important. That sort of remote educational intervention went on for about a year. You know, if they had questions or whatever, they could call us. But otherwise, it was essentially one in-person visit and a few by mail visits. And we wanted to see how they would handle Mary. Now, I forget where we are. Are we on a slide that says, is bias operant for all medical conditions?
Yes.
Okay. So there's Mary again and her variety of medical problems, and she's a current smoker, and we want to try and understand what the heck is happening in terms of decision making. So next slide. In this group of physicians in the field, these are not academicians. These are not folks who necessarily feel compelled to tell us the answer we want them to tell us. We see exactly the same pattern. Pre-instruction, the value of tobacco to the community is for every dollar they spend on diabetes, they will respond, I want to spend over $2 more on tobacco in terms of value to the community. But look at the probability of success. Compared to diabetes, probability of success is actually pretty low. They just don't see themselves as successful. After this sort of scalable type of instruction, you get the price reversal pattern that you're looking for. The utility of tobacco to the community is as high as diabetes at least, but the probability of success of tobacco interventions has doubled compared to what they see as the probability of success with diabetes. And that's exactly the pattern that we're looking for, because we know that that pattern actually changes what the willingness to invest of yourself into the problem. All right, so next slide. This slide's actually a little bit difficult to follow, but basically we compared their price reversal to responses they gave both pre and post in terms of their categorical estimates of frequency of certain behaviors, tobacco use behaviors. And while we recognize that these categorical responses don't actually translate one-to-one into actual numerical, you can't really decide exactly what the frequency is when somebody says almost always. But we do know that when almost always changes to always or whatever, when somebody changes from sometimes to almost always, that change actually does reflect a similarly direction change in quantifiable data. So we're looking at this qualitative stuff, and we notice that the scores in terms of the simple behaviors almost always, but the complex behaviors like prescriptions, follow-up visits, referrals, almost never. Big difference in terms of type of behavior. Then at the bottom of the table, baseline to follow-up comparison. Simple, it was already right delimited. People reported almost always doing it anyway, so there was very little change. There was some, and it was significant, but because we had over 250 people in this sample. But the complex behaviors is really where the money is. They went from almost never to sometimes. And even though that doesn't sound all that encouraging, there's almost a 10% change in the number of people who were reporting almost always or always. And that's a huge change as far as clinician behavior change is concerned after a single educational intervention. So we felt like we were on the right track as far as trying to change clinician behaviors based on biases. And we wanted to understand if it was only cognitive biases that were influencing decisions, or if there was something deeper to that, something really non-cognitive, very sort of instinctive, and we were concerned about fundamental attribution error. So next slide, please. In a sample of 100 primary care clinicians from around the country, these are folks that we engaged randomly out of a phone book, essentially, and asked them a bunch of questions, and then we asked them, the question that we think was really sort of most important was, what's the single word you would use to describe your how you feel when you're dealing with hypertension? We asked them the same set of questions, the exact same set of questions. The only difference was we sort of find and replace the word hypertension with tobacco. And so the two single word association questions were essentially asked looking for differences between and how they felt between hypertension and tobacco. And if you notice, they broke down into a couple of categories. How important was it to the patient? They used words like important, a priority, beneficial. They talked about technical or professional attributes. It's challenging, it's routine, it's too frequent, it's easy. The pharmacology works, it's time consuming. They talked about the character of the patient. The idea of patients being stubborn was actually quite common. And here's where we really felt like the money was. Under clinician emotions, a lot of the single word responses involved unfulfilling, frustrating, rewarding, successful, relentless, that sort of thing. Next slide, please. I think next slide as well. Okay, so now you should have the two red asterisks over frustrating. Do you see that?
Yes.
Okay, that is the only word that was different between hypertension and tobacco. Clinicians felt that taking care of hypertension was also too time consuming. They also felt like they didn't have enough background. They also felt like the pharmacology, they either felt like the pharmacology was useful or that the pharmacology was not useful enough. They felt the same degree of patient characteristics as stubbornness, etc. They felt they had the same exact sense that treating hypertension was unfulfilling or boring, or conversely rewarding and great. The one word that showed up for tobacco that did not show up for hypertension was frustrating. And it's important to understand that the word frustration is actually very important because, next slide. Oh, damn. Next slide. I next slided too early. So this is just a graphical representation with the blue and the green of exactly what it was that we just talked about. Next slide, please. Here you should see a special case of framing causal controllability. Okay? Causal controllability is this notion that clinicians are much more willing to give help if they see the problem as out of the causal, the controllable causal framework on behalf of the patient. So Mary's hypertension has nothing to do with whether she caused it, but her diabetes does. And we actually apply this fundamental attribution error framework in our daily lives in all kinds of different ways. So for example, when you're driving on the parkway and someone cuts you off, the degree to which you interpret or perceive that person as different from yourself, as having a character flaw, something intrinsically wrong with that person's judgment, that is really basically an individual cause of their failure. So the failure is they cut you off. If it's about their character, if it's because they're different than you, that's perceived as an individual cause to the failure. But if you imagine if somehow you perceive that person cutting you off as a function of social causes, maybe the person right in front of them was acting erratically on the parkway, and you notice that. And so when they cut you off, it was sort of because they had to, because social circumstances dictated that they move into your lane quickly. Then you will see that failure very differently. For failures that have social causes, we view responsibility as essentially ownership. That guy cut you off, but he had to. He owned the problem of erratic driving on the part of the other parkway colleagues, and he had to move into your lane. But for failures that we identify as related to individual character causes, that responsibility is interpreted as culpability. And culpability results in anger. Anger, frustration result in an unwillingness to provide help. Whereas if it's about social causes of illness, the overriding emotion is pity or sympathy or something along those lines, and actually amplify willingness to help. And so what we wanted to do was try and figure out whether the type of responsibility that physicians perceived for smoking was related to culpability, right, intrinsic character flaws, or ownership, social causes in terms of whether or not it's easy to stop smoking. Next slide. We did this inquisite test, which is implicit association testing. You guys may have heard about implicit association testing. An implicit bias is a bias that may be unknown to us. We're not aware that the bias exists, but is a result of a whole lifetime's worth of signals that make us feel like one position is more correct than another position. So we wanted to try and identify whether or not there's an implicit bias around smokers as culpable people. Next slide. And this is just an example of how the testing goes. The first part of the test asks you to sort words that have dichotomous meanings. So here at the top of the page, you give the idea of kind or kindness, and then on the right would be the idea of mean or meanness, and then the computer flashes words, and by using the keypad, you have to sort the words to the left side of the page if they mean kind, or the right side of the page if they mean mean. So next slide. So your arrows, next, and then next slide again, you see the arrows would go from, the synonyms would go from the left or the right. Okay. Next slide. Now you should see a slide that is titled Assorting Tasks, Then Objects. Okay, are we there?
Mm-hmm.
Now all of a sudden the computer is no longer sending you words. It's actually asking you to sort pictures. And in this case, in this example, you're sorting pictures of Mother Teresa to the left and pictures of Osama bin Laden to the right. And that should actually be pretty simple. That should be an easy task. Mother Teresa, next slide, Mother Teresa goes to the left, and on the next slide, bin Laden goes to the right. And then on the next slide, you ask for the sorting of compatible ideas. If words that mean kindness or pictures that mean Mother Teresa show up on the page, they're to be sorted to the left. But words that mean meanness or pictures of bin Laden should be sorted to the right. Those two ideas are now compatible. So that should be an easy thing to sort. But in the final task, you ask people, next slide, you ask people to sort incompatible ideas. Kind or bin Laden just doesn't go. Mean or Mother Teresa just doesn't go. And so you can imagine that in order to sort these ideas, it's going to take you a lot longer to do. Next slide, please. Yeah, so that's the notion that graphically, it's going to take you a lot more time to sort kindness and bin Laden than it does to sort meanness and bin Laden, okay? Next slide. And so when we ask clinicians to sort notions of guilt versus notions of innocent alongside pictures of smokers, notions of guilty paired with pictures of smokers took about a second on average. But notions of innocent paired with pictures of smokers took almost 2 seconds on average. And so here we felt like it was the first time that anybody's really identified not just it takes time, it's complicated, I don't know what I'm doing, but the potential for an implicit bias of association between smoking and culpability that actually had the potential to influence fundamental attribution error and influence willingness to provide care. Next slide. So a couple of points to remember. Inaction among clinicians is not because of a misunderstanding regarding the importance of tobacco to public health. So the classic sort of approach, every time the Surgeon General writes a new Surgeon General's report, the first page has how many people die of tobacco dependence. So an approach to changing behaviors, improving quality on a system level that focuses strictly on the motivations to stop or to change, are going to miss the mark. They already understand how important it is. They already assign very high community-based utility to tobacco intervention. It really comes down to a low a priori estimation of success probability that appears to influence willingness to invest. That's referred to as the preference reversal. And so our focus has to be on changing the estimation of success probability in a number of different ways. We used biases, cognitive biases and heuristics, and a training approach along those lines to change the probability of success and change the likelihood of meaningful clinical interactions. We believe that implicit bias is in there, and that if we could figure out how to train around that without offending a lot of people, that we want to talk a little bit about the difference between culpability and responsibility or ownership, and really talk about the social influences over a person's ability to quit, or I should say conversely, probability that they'll continue smoking. And then the third point is that the relative poor rates of complex clinical behaviors appear modifiable through focused interventions, reframing bias. It's not enough to ask and advise, because that's easy, everybody does it, and it's not very effective. If you're going to think about improving the quality, the systematic quality or approach within a health system, you really need to think about changing the likelihood of more complex behaviors, and that is a bigger nut to crack. Finally, implicit associations with guilt may help explain frustration and willingness to give help. We think that that's an important point that has not been fully explored or addressed in terms of how to work around that or how to manage that implicit bias. Next slide. I put up a couple of web resources that we try to maintain. We're not as good at it as we'd like to be, but some of this might be useful to you. The penmedicine.org/penstop is our main web page. It has some information for clinicians on there. We also do a training, so /tobacco training. There's a number of different webinars that are posted on there, and announcements of CME events and that kind of stuff. Excuse me. And on Twitter @PenMedTobacco, we post once a week. We post a paper that we feel like is important information to help people feel a bit more comfortable treating tobacco dependence. So how do we get to be better treatment clinicians once a week on Twitter? So if you guys follow Twitter, follow us and you'll get that info. Next slide. This is kind of how, sort of ironic, and actually it turns out that for about 5 years I'd never realized the irony until someone in the front row of one of my talks pointed it out. I used to say, I end every one of my talks with this saying because I feel like it's so important. If we always do what we've always done, we'll always get what we've always gotten. And then somebody raised their hand in the front seat and said, so wait, you end every single one of your talks, you always end your talk with the same. I'm like, oh my God, I'm so embarrassed. But the truth is, our notions around tobacco are difficult to change. They are born of a lifetime's worth of experience, not just as doctors, nurses, healthcare providers in general, but really as people. And those notions frame our approach, our willingness to provide care in more fundamental ways than we're sort of even aware of. And I think that that's really where the next level of understanding is going to come from, not just telling them what to do, not even just telling them how to do it, but really talking about the reasons why doing it so far may have been harder for them than they thought. I'll leave it there and take a couple questions from the audience. That's cool, you guys clapping for a conference phone. Thank you.
So I have a question. Thank you very much for this really great talk. After your 1-year intervention, you count, I don't know, the number of patches that were administered or whether patients had quit smoking or something like that after your 1-year interventions in the community, among physicians?
Right. So we're actually in the middle of that study now. I don't have that data for you yet, but I can tell you that the sort of initial stuff looks good. And what we chose because of funding priorities, but if you repeat that to anybody, I'll deny it. Anyway, we chose the context of like outpatient behavioral health clinics. So it's not exactly primary care, but we made the argument that the same fundamental processes were likely to be operational regardless of the context. And so what we're doing now is actually testing a method that focuses exclusively on teaching around bias, et cetera, versus sort of standard practice. This is a patch, this is how you use it. And there, in that study, we're actually capturing patient-level data. So, it's all provider attitudes, provider self-assessment, but then we're going to patient charts to confirm whether or not the rate of prescriptions or the rate of referrals and that kind of stuff is actually changing. And so far, it looks pretty good. We'll see how it ends up in the end.
Well, that's great. Wow.
Yeah. Give me a couple more years, and then you'll read about it, hopefully like in the New England Journal or something.
Yes, you come back, tell us the results.
Yeah.
Yeah, thank you. This was a wonderful talk. Given the current opioid crisis, are you aware of any similar efforts that are underway to address other substances such as opioid use?
No, not so much. I feel like, one of the things that makes the opioid crisis so different is really the public outcry. And, you know, for decades, people were dying from narcotic overdoses, but there weren't a lot of people out there advocating on their behalf. There were families that were hit by tragedy, and that's that. But in the past couple of years, there's been an organized approach to take the numbers of people who are suffering from that problem and essentially shoving them in the face of politicians. And that's what's created this focus on it. It's a good thing. That's a good thing. But that focus all by itself changes the sort of bias framework. No matter what clinicians feel about culpability, they also know it's their responsibility to treat this problem. If they don't, there'll be this sort of social, there's a social acceptability or social affirmation bias that they're responding to. So all we really need is an organized, you know, advocacy group of really angry people, smokers, people who are like, hey, how come you're not taking better care of me? And that's just not happening. People who smoke feel the same sense of guilt and culpability as everybody else. And they, you know, they're ashamed. They just don't feel it yet. So I feel like we have a ways to go with tobacco in particular because it's so ubiquitous, so universal, and so much about shame. Nobody really feels like, you know, even like cancer patients, they will affirm that their cancer is their fault rather than the social circumstances around their cancer. It's kind of horrible, really.
Do you have a question? Any other questions for Dr. Wu?
I have a question. Thank you very much for the talk. Very interesting. You measured two numbers. The first one is how much you invest in the community. The other one is the bet. And then it seems your primary study on the bet part. But I also noticed, is it right to say that the first number also goes up after the intervention?
Yeah.
The investment.
Yeah, sometimes it does. Sometimes it does.
So did you study the difference? What might be causing the difference? Sometimes it does, sometimes it doesn't seem have statistical significance.
Yeah, that's a really good question. We actually didn't really think too hard about, you know, how important doctors would feel that this problem was to the community. Mostly that's because it's just we wanted to actually show the other side of this coin, but also in retrospect, it's also because it's sort of right delimited to begin with. People really place a lot of emphasis on tobacco. You hear it in conversation. The most important thing you can do, Mary, is, right? And so they already see that high. So we didn't really think too hard about investigating the reasons why importance to community might actually change. That's a very good question.
Thank you. Any other questions? Okay. Thank you very much.
All right, thank you guys. Take care.